So we'll start with the why. So why does smoking during pregnancy matter? It's the single biggest modifiable risk factor of poor birth outcomes. There's several risks associated with smoking during pregnancy. We know that there's a risk of slower development and possible of unhealthy birth weight is increased. We know that an unhealthy birth weight can result in more vulnerability to infections and therefore requiring possible medical intervention after birth. It can also impact their respiratory system, and increases the risk of cot death and the possibility of the baby developing birth defects. You may have also heard at the beginning of the week the research done by the University of Aberdeen. They identified a genetic link to smoking in pregnancy. So they found that males experienced more long-lasting effects when the mother smokes during pregnancy, including dying younger if they go on to smoke themselves when compared to females. There are also health risks associated with smoking during pregnancy for mothers. It can impact their birthing experience and their pregnancy experience. We know that quitting smoking is the best thing that a pregnant person can do for their own and their baby's health. We know that there are many benefits of quitting smoking for both the mum and the baby, and this also includes the financial benefit for them and their new family that may now be available now that they've quit. So e-cigarettes and stop smoking support during pregnancy. We'll start with e-cigarettes, and the World Health Organization advises against using e-cigarettes during pregnancy, as nicotine exposure can harm the fetus. Many e-cigarettes do contain nicotine, and an evidence briefing published by the Scottish Government in 2024 found that there was insufficient evidence available to make a conclusion on the health effects of vaping on pregnant women and their babies. And also dual use by pregnant women is when they use both e-cigarettes and cigarettes during pregnancy, and this does not reduce the harm and may increase exposure to harmful substances. There may be many mixed messages around the use of e-cigarettes during pregnancy, and we know that there are safer alternatives that can be used during pregnancy. So individuals should speak to a member of their maternity care team about e-cigarette advice in their area. We know that NRT and behavioural support can result in a 4 times higher chance of a successful quit, and that pregnancy brings about more frequent interaction with healthcare professionals. Pregnancy can be a huge motivator, as this period represents a unique window of opportunity when many pregnant individuals feel motivated to adopt healthier behaviours. So we'll have a look at some demographics for smoking during pregnancy. Some of us might have a higher susceptibility to becoming addicted to nicotine compared to others. So the likelihood of becoming addicted is not equal for everyone. So here we can see the average percentage of those at first booking appointment and how it's changed over time. The percentage of those that smoked at first antenatal booking in 2023 was 11%. The rates have declined over the years, and smoking rates are 8.5 times higher in the most deprived communities, which is SIMD level 1, compared to the least deprived at SIMD level 5. Children who parents or caregivers smoke are 4 times more likely to take up smoking themselves. Additionally, we know that the tobacco industry uses targeted marketing strategies in areas of high deprivation and also directed at young people. So we'll go on to our consultation phase, which, as I said, happened between 2023 in November up to 2024 in May. What we did is we met with representatives from all 14 health boards across Scotland. And we also compared this to midwives' insights from the survey that we did. We asked a range of questions, including about their referral pathways and resources they currently provide. We also asked about language used with pregnant women that smoke and any barriers that they came across to conversations about cessation. We also asked about their experiences with e-cigarette use during pregnancy in clinical practice. So now I'll go over our midwifery survey results. We received over 130 responses from midwives representing all health board areas. Most of the responses were from areas that were mostly community-based rather than hospital-based midwives. And here we can see the areas of respondents where midwives were based. We can see mostly they came from Tayside and Forth Valley. We asked whether midwives were aware of their services referral pathway to smoking cessation services. We found that 86.6% of midwives were aware of their referral pathway to smoking cessation services. We wanted to break this question down into further points. So we also asked about incentive schemes, opt-in or opt-out referral processes, the mode of contact used by the health board, use of badgernet, and also CO monitoring. So that we asked about the health board area's mode of contact. We asked how they contacted pregnant women when referring them to smoking cessation services. This ranged quite widely depending on the area. Some used a blocked number, others used a recognizable number, and some utilized a text message service before they offered the phone call consultation. Some areas offered face-to-face appointments, others only offered over the phone since the pandemic, and the time given for pregnant women to engage with services differed across health boards. We also found that the language used when asking if the pregnant woman wants to be referred is very important to ensure that they don't feel judged. We also asked health boards whether they utilised incentive schemes and the consent procedures used in the area. We asked about opt-in or opt-out services, and an opt-out referral pathway is where consent to engage with services is presumed if they don't refuse, as opposed to opt-in where the patient chooses to engage with smoking cessation services. We also found that some areas asked, do you want to be referred to services, while others didn't give the choice. So the way that further support is phrased to quit smoking for pregnant women matters. Given that there are no Scottish equivalent NICE guidelines for smoking during pregnancy, we rely on these NICE guidelines, which suggest, if necessary, make at least three contacts with the pregnant woman using different methods. Advise the maternity booking midwife of the outcome, but the practice does reflect differences here. Incentive schemes are also recommended by NICE guidelines and should be rolled out, and the opt-out services should also be used and rolled out according to NICE guidelines. We also asked about badgernet. Badgernet is an electronic health recording system that most health boards in Scotland do use. It allows patients to access resources through this system and allows healthcare professionals to make resources available and assign them to patients. We found that some areas are not able to record the rates of e-cigarette use during pregnancy. And another key finding was that the use of CO monitoring across Scotland differed. One midwife stated that they think that we should be doing more with CO monitoring to increase women's understanding of the impact of smoking on their unborn baby, and that this is a good tool to open these conversations. We also asked midwives about their general views of their overall referral pathway. And here are some quotes from the survey. They really ranged from positive to negative. There was comments on badgernet and the ease of the referral pathway. They spoke about wanting feedback as related to whether the pregnant woman engaged with services, and there was comments on CO monitoring as well. So now we'll go on to have a look at the barriers to the conversation for pregnant women that smoke. We asked midwives about barriers to having the conversation about smoking with pregnant women. The top barrier that was reported was e-cigarettes and the mixed information about use during pregnancy. And you can see some other barriers that were stated here as well. We'll have a look at the barriers in more detail. We found that some health boards do provide support for pregnant women who use e-cigarettes, but that most do not. Midwives also requested more information about NRT use during pregnancy. We found that NRT during pregnancy is delivered differently across health boards. Some do not have access to the same products that are available, and some offer NRT to pregnant women who use e-cigarettes and some don't. Finally, here are some midwives' quotes on the issue of misreporting by pregnant women. So we'll have a look at the other barriers now. This misreporting may come from the fear of being judged or shamed, and midwives felt that it was difficult to speak to women about this. We also explored the lack of support and the conversation around this. There's an expectation that pregnant women who smoke will go home from their booking appointment and speak with their family members about quitting smoking. This is where resources may come in handy to prompt the conversation and provide accurate information. Midwives also felt that their own lack of knowledge and the confrontation of myths by pregnant women was a barrier. Some myths included, when my mum was pregnant with me, she smoked and I turned out fine. Smoking calms me down, and quitting will actually stress me and my baby. But we know that nicotine triggers a surge of dopamine, and this is what gives you that sense of calm and reward. Over time, dopamine begins to drop, and you experience more withdrawal cravings for more nicotine. So what's perceived to be relieved is actually relief from withdrawal. Another barrier for midwives was time. So some midwives suggested that they lack time that is necessary to speak about quitting smoking and resources that are available. We asked midwives to rate their current confidence and knowledge in relation to e-cigarette use and smoking during pregnancy. We asked midwives which areas they would like to receive further training in, and most requested was e-cigarettes. We found that mostly their confidence and knowledge lacked in e-cigarette use during pregnancy, and they were most confident and knowledgeable about directing pregnant women who smoke to stop smoking services and generally smoking in pregnancy. So we asked, as mentioned, the start of this project was really to do with providing materials and resources for midwives to pass on to pregnant women that smoked. We received over 130 responses to this question around what resources are currently available in your service to pregnant women that smoke. The most reported resource was I.Quit. So this is an online booklet that is available, but we found that when you Google I.Quit, as pregnant women might do after their booking appointment, information for a vape shop based in England also comes up. We also found other links to the site were broken. The I.Quit booklet has been made available only online and has been updated in February last year. These are the other most requested resources that we found. We also found that some health boards have their own teams to create resources and update them. Others said that they were in need of resources. Some midwives responded to this question that they had nothing in terms of resources to offer pregnant women that smoke. Overall, we found that resources are being requested, and so it is more training by midwives, and health board representatives agreed. We received 48 suggestions for different resources that could be beneficial. And health board representatives and midwives stressed the need for resources to be available online, digitally, and via paper copies. For example, if you live in a rural location and don't have access to internet. And resources should be translated to multiple languages and are easily accessible. We found that the quantity of resources differed across Scotland. Several midwives said that visual information and short videos, like on a TikTok sort of format, or animations are received very well. We then asked if there was anything specific missing in terms of support, resources, or training. We received a range of responses to this question. We found that the most requested training module subject was e-cigarette use. When we asked health board representatives what training they would like to see for their midwives, they mostly requested CO monitoring, but interestingly, this was least requested by midwives. We also asked what kind of support midwives felt that pregnant women needed, and most often they requested mental health support like counselling and peer support, perhaps on social media platforms like Facebook for pregnant women to get together and support each other. So Ash Scotland identified a significant confusion around the use of e-cigarettes during pregnancy. And this was largely attributed to conflicting messages. Based on these findings, we've created new resources based on the requests from health board representatives and midwives. We've updated our smoking and pregnancy briefing, created an animation video about smoking, vaping, and some information on NRT during pregnancy. We created 2 infographics, one on NRT and one on just general pregnancy and smoking. And we've responded to further training requests. So we're creating a e-learning module for midwives, which will be live and ready to go in April. And we're providing training materials for university students. We do understand that it's not all midwives' jobs in all areas to deliver smoking cessation support, but they're likely to be the first person who identifies the need for further support. So it's important for them to be equipped with this knowledge. Our 3 resources that you can see in the pictures here are currently being piloted. So we've received most of the responses from all areas of the pilot now. So we'll be revising these and updating them in the coming months. In the future, we plan to develop and pilot, or finish developing and pilot, this e-learning, collaborate in the future with universities to provide and pilot the materials, and provide ongoing collaboration with Public Health Scotland to facilitate the tobacco dependency and pregnancy group. We also want to continue updating or providing further resources to health boards. So, conclusions. We recognise that there are efforts to discourage prenatal smoking should be intensified. There's a need for a national approach to reduce smoking rates during pregnancy across Scotland, but we do recognise that a single national approach may not fully capture or address the diverse priorities, needs and regional variations across Scotland. Nevertheless, a statement around e-cigarette use during pregnancy may reduce confusion experienced as found during this project among those that work with pregnant women who smoke or use e-cigarettes. Thank you. And if you do have any other questions or want to learn more about this project, please don't hesitate to get in touch.
My name is David Tappin. I was a pediatrician and I retired from clinical work in 2019. Today I will talk about smoking cessation in pregnancy, which I've been researching for 32 years. I've undertaken a number of trials looking at smoking cessation during pregnancy, as well as observational studies looking at the damage caused by smoking. I initially looked at motivational interviewing as an intervention to help pregnant women to stop smoking, and then moved on to financial incentives, finishing with a multi-centre UK trial. Today I will be talking about the damage caused by smoking during pregnancy, my and others' experiences of effectiveness of motivational interviewing to help women who smoke to quit during pregnancy, and I will try to give an unbiased view of the effectiveness of interventions for pregnant smokers. And finally, I will give you my view of an effective intervention strategy. When looking at the detrimental effects of smoking during pregnancy, many people forget the effects on the mother. Also, young women may not attend health professionals as they are well. Pregnancy is an opportunity to help women to stop smoking before their health is permanently compromised. An interesting study looked at doctors over a 50-year period and the effects on lifespan of when they stopped smoking. It found that if doctors gave up smoking between 25 and 34 years of age, their life expectancy was that of a non-smoker, the dashed blue line in the figure shown. If they gave up between 35 and 44 years, they lost about 1 year of life. Whereas if they gave up later, they lost 5 years of life compared with not smoking at all. And if they didn't give up, they lost 10 years of life. The point is that childbearing years are up to 44 years. So if women give up during this period, they only lose at most 1 year of life on average. So quitting during pregnancy means that women who quit will have a normal lifespan, whereas those who continue to smoke will on average die 10 years earlier. 80% of women have at least one baby. So smoking cessation during pregnancy is a very effective opportunity to improve lifelong health of women. For children of mothers who smoke, 27% of small gestational age babies are attributable to smoking during pregnancy, as are 20% of unexpected deaths in infancy, 10% of stillbirths, 5% of early miscarriages, and 7% of premature babies. Maternal smoking is responsible for many hospital admissions, including 7% of respiratory infections in children, 10% of bronchiolitis, 7% of asthma admissions, and 12% of admissions for bacterial meningitis. 400,000 UK children are pushed into poverty because parents spend part of the household income on cigarettes. Because small deprived women and their partners smoke, parental smoking increases health inequalities. I now want to talk about motivational interviewing in relation to smoking cessation during pregnancy. And motivational interviewing is an effective way to begin to talk to pregnant women about smoking, a health behaviour that is often damaging to themselves and their offspring, and how it fits into their lives. The style of motivational interviewing, quiet, respectful, non-confrontational and collaborative, is far more appreciated than the traditional concerned but hectoring manner of many health professionals. Once smokers are engaged and talking, they can tell us if they want to quit, and we can provide appropriate behaviour therapy to aid a quit attempt. For these reasons, in the 1990s, motivational interviewing was a promising intervention to help pregnant smokers to quit. We asked a research question: will the addition of home-based motivational interviews by specially trained midwives increase the quit rate by the end of pregnancy from 7.5% to 15%? We undertook a pilot study with 50 participants in each group, and then a full trial in one centre, Glasgow. Training was undertaken by Jeff Allison, a health behaviour change expert trainer, and he taught 3 research midwives over 8 days, followed by mentoring 1 day per month, using the midwives' own transcribed interviews throughout the trial. 351 women were randomised to the offer of 4 home-based motivational interviews, each lasting about an hour. 411 women were randomised to routine care, which at the time was a brief intervention from their routine midwife at the time of antenatal appointments. (17) 4.8% quit towards the end of pregnancy in the intervention group, and 19, 4.6% in the control group. There was therefore no effect of the motivational interviewing, or the offer of motivational interviewing. Questions to ask in this situation are: did the intervention take place? 25% of intervention women could not be contacted to arrange a home visit and were never in when the midwives visited on the off chance. 30% had 1 visit, 16% 2 visits, 8% 3 visits, and 21% 4 or more visits. A second question to ask is: was the intervention good quality? All 625 interviews were audio recorded. A 10% random sample, 63 interviews, were sent to New Mexico to be rated for motivational interviewing quality. The result was that intervention was proficient and often expert. Person at the rating centre was that: I want to tell you again how much my coders enjoy coding your sessions. They hear a lot of not so MI, and the quality of counselling delivered by the midwives was really outstanding. So comparing all interventions for pregnant women to quit smoking, A number of studies have been undertaken. A Cochrane systematic review has been updated 9 times now, looking at psychosocial interventions for supporting women to stop smoking in pregnancy. That tends to be anything apart from drugs. A trial of electronic cigarettes versus nicotine patches has been undertaken, and a Cochrane database of systematic reviews has looked at incentives for smoking cessation, including a group of trials for pregnant smokers. Looking at non-drug interventions, brief advice and materials alone allowed 3% of pregnant smokers to quit. Counselling, often withdrawal-orientated therapy, added a further 3.1% improvement, so 6.1% of people quit. Adding an opt-out system, a true opt-out system where all smokers are referred to stop smoking services, increased the quit rate from 3% to 8.1%. Adding motivational interviewing actually made no difference at all. And adding an SMS specific SMS intervention by texting increased the stop smoking rate from 3% to 6.4%. Most interesting to me is the opt-out system, which means not asking women if they want to take a carbon monoxide breath test, but assuming they do unless they opt out spontaneously. And then referring all self-reported smokers or those with the raised carbon monoxide to stop smoking service without asking the women. Now, with a new baseline of an established stop smoking service where the quit rate is around 6%, e-cigarettes improve quit rates more than nicotine replacement therapy and increase the quit rate from 6% to 11%. Incentives improves quit rates by 10% from 6% to 16%. And physical activity has little or no effect. As a pediatrician, I find it difficult to advocate the use of nicotine replacement therapy and would find it very difficult to advise the use of e-cigarettes, or particularly to prescribe them, as they're not regulated. So you really don't know what's in them. Moving back to financial incentives. This figure from the Cochrane review shows that the certainty of the evidence is high of all the trials that were looked at. This means that Cochrane advocate the use of financial incentives. We undertook a multi-centre trial in Scotland, Northern Ireland and England. The trial used a simple incentive structure with a £50 voucher if the participant attended for a first meeting with a smoking cessation advisor and set a quit date. A further £50 voucher if not smoking after 4 weeks, confirmed by a carbon monoxide breath test. A £100 voucher if not smoking after 3 months, confirmed by a carbon monoxide breath test. And a final £200 voucher if not smoking in late pregnancy, again confirmed by a carbon monoxide breath test. I undertook an economic evaluation and a qualitative study describing in detail the very varied nature of stop smoking services for pregnant women in the trial. Varied formats are the subject of a recent paper and described in this rather complicated table. It could either be pregnant women or the general population, and the behaviour change supported was smoking only, smoking and weight management, or in one place, smoking, alcohol, weight management and physical activity. The Stop Smoking service was funded by local government, NHS trusts or health boards, a public health body, or NHS Health Improvement. The location of the line management was sometimes not the same as the funder. So NHS trust and boards could line manage a service that was funded by local government, for instance. Your Stop Smoking service could be hospital consultation room, community venues, or regular drop-in centres out with hospital premises. This just shows some of the variety of the services, which were all very different. You may ask if this intervention can be integrated into current services and if it still works. The Glasgow before and after study integrated financial incentives into real life and overcame many of the problems of integrating financial incentives into a real stop smoking service for pregnant women. The Khan report recommends £15 million per year to be used to fund financial incentives for smoking cessation during pregnancy in England. This is being rolled out by a group in Manchester. These are my must-haves for a smoking cessation service for pregnant women. Use a truly opt-out format to refer all pregnant smokers and those with a raised carbon monoxide breath test to stop smoking services. Stop smoking services should utilise counselling methods, withdrawal-orientated therapy specific for smoking. And Stop Smoking service should offer financial incentives for smoking cessation during pregnancy. Thank you very much.
Hello, my name's Michael Ussher. I'm a Professor of Behavioural Medicine at University of Stirling and City St George's in London. So I'm going to present you today the main findings of a recent review we published about vaping and pregnancy and effects on health outcomes. Just like to acknowledge the co-authors of the review, and there's the citation for the publication if you want to look at it in more detail. So for a start, why is this review needed? Well, there's increased interest in vaping and pregnancy. Women seem to be using vaping more and more for smoking cessation and harm reduction in pregnancy. This is shown in recent US surveys, such as the one I've referenced below. And we haven't got recent data, national data in the UK, but we know from 2 recent large trials of women that were recruited that stopped smoking in pregnancy, 25 to 30% of the women had vaped in pregnancy. So there's certainly increased usage. There's also some evidence for the effectiveness of vaping for smoking cessation in pregnancy that comes from one trial, this trial led by Peter Hayek, which I've referenced below. And in recent years, particularly the last sort of 2 or 3 years, there's been a big expansion of number of studies looking at vaping and pregnancy outcomes and birth outcomes. And we wanted to update the evidence. Just want to give a bit more background about why we might be concerned about nicotine and also about vaping in pregnancy, the nicotine and the other additives that are included in the vapor. Well, just looking at nicotine, there are some animal studies showing adverse effects, particularly in in the fetal lung, cardiovascular system and brain. And there's some plausible mechanisms why there might be those harmful effects. But caution's needed in extrapolating these findings to humans, because they're all done with forced chronic exposure to nicotine in the animals. They're nicotine naive animals. And that's quite different than having intermittent self-administered nicotine that humans have. So in human studies about nicotine replacement therapy, the systematic reviews and meta-analyses of the randomized controlled trials still conclude there's unclear evidence about whether NRT is likely to be harmful to the fetus. Even though there's generally better outcomes for NRT users, that's likely to be due to NRT users smoking less. But one of the issues in these studies is that generally the women are using low levels of nicotine replacement therapy, and it's not clear how the outcomes would be if they're using more consistently higher levels and for longer periods. We need some longitudinal cohort studies where we're looking at natural use of nicotine replacement in women in large numbers, and then controlling, looking at how much smoking they're doing at the same time. So it's difficult to conduct those sort of studies. So this current review, we're mainly comparing those who are exclusively vaping with those who are not using any nicotine tobacco products, and also comparing exclusively vaping with those who are exclusively smoking. So we're looking for those sorts of studies, any quantitative studies reporting health consequences of vaping in pregnancy, and as we searched up to November 2023. So we didn't do a meta-analysis where we combined all the results, because we considered all the studies to be of too poor a quality to put into a meta-analysis. And we looked at the outcomes related to the mothers, the fetuses, and the infants. So we identified 26 studies altogether, all fairly recent studies in the last 4 years. There was one randomized controlled trial, the one I've mentioned, which compared vaping and nicotine replacement. The rest were cohort studies. So either retrospective studies, so they were asking people to report their use of products back in time, or prospective ones, which ask people to report product use across time at the time. They're mostly US studies. So what the main features, so not all the studies compared these key groups that we're interested in. Only 15 of the studies compared exclusive vaping and non-use, and 8 compared exclusive vaping and exclusive smoking. Quite a number of them had small sample sizes, which means it was unrealistic that they were going to find differences between the groups. So amongst 20 studies with exclusive vapors, 10 of them had less than 30 participants. And not many of the studies at all had any biochemical verification, and none of the observational studies, the cohort studies, verifies both smoking and vaping. One of the studies that did check exclusive vapors for smoking found a large number of them evidence for smoking. So that's really important. I'll come back to that, but that's a really important omission. Also, there wasn't a good recording of whether we're using nicotine or non-nicotine vapes. So in 17 studies, it wasn't clear whether the vapes contained nicotine. And again, only the randomized control trial adequately assessed the duration and frequency of vaping. There's very little monitoring of the use of other nicotine products, and also they're not looking at exposure to secondhand smoke. So overall, we considered all the studies, apart from the randomized controlled trial, to be of poor quality, because they didn't adequately assess exposure to smoking and vaping. So it wasn't clear if they were smoking currently, because there was little biochemical verification, or it wasn't clear if they'd been smoking previously, So a lot of them, for example, only assessed smoking during the last month or late pregnancy or recently, basically. So there could have been earlier smoking in pregnancy, because most women who vape are ex-smokers. So the main findings, I'm just going to summarize. There's a lot of detailed findings, quite complex findings in the paper. I'm just going to summarize the main findings here. So for studies comparing exclusive vaping and non-use, we found overall more studies reported no increased risks than reported increased risks. So basically finding that exclusively vaping is quite similar to non-use, so not much evidence for risk there overall. But when we're comparing exclusive vaping, exclusive smoking, most of the studies found a similar risk, which suggests there's a similar risk of vaping and smoking. I mean, so first thing to say is these two sets of results are conflicting and don't really make sense. And I mean, I think overall the results are inconclusive, and because there's such a pattern of different findings in the different studies. As regards dual use, most of the evidence reported dual use having a comparable risk to exclusive smoking and increased risk compared to exclusive vaping and non-use. The randomized controlled trial didn't find any evidence of adverse outcomes when comparing those who were absent from smoking and vaping or using nicotine replacement with those using no products. The limitations, though, of the randomized controlled trial, because there were only 25 individuals in the group not using NLT and vaping, and we weren't able to separately look at vaping and NRT effects in that trial. So overall, as I say, the findings are inconclusive as there's mixed evidence. The studies are generally of very, very poor quality, except for the randomized controlled trial, because they don't adequately assess exposure to the products, especially smoking. Therefore, we can't really interpret the implications, interpret the findings. So where there's heightened risk reported, it could be due to high levels of smoking, either particularly previously, or they could be currently smoking as well, because there's very little biochemical validation. On the other hand, where there's no risks reported for exclusive vaping, this could be because there's very low levels of vaping. For example, if the population is anybody who's vaping, it could be possible that some individuals have only vaped a few times, but they're included in the sample, and then the overall effect might come out as there's no effect of vaping because there's very little vaping being done. So the implications are we need more large longitudinal, so following up women across time throughout pregnancy and after pregnancy, women that are naturally using these different products. Ideally, we need to look at women who are exclusively vaping from preconception, because then there's no risk that any effects on outcomes can be contaminated by smoking. And we also need to have, of course, smokers from preconception, comparing with those who have never used any nicotine tobacco products. We are currently conducting a study along these lines. It's being focused in Greater Manchester, where we've got about 35,000 births, so a good catchment area, and they've got a good data platform there for collecting all the data across pregnancy. And in that study, we've got very rigorous assessment of product use at different multiple time points with saliva samples as well as carbon monoxide. We're checking for use of vaping, nicotine products, and smoking. So that study's only just started at the moment. We've also recently conducted a biomarker study where we've taken urine samples from women early in pregnancy, and we've looked at indicators of toxicants and carcinogens early in pregnancy, comparing exclusive vapors with exclusive smokers and never product users. And overall, we've found that the levels of the biomarkers are similar for non-users and exclusive vapors, and much lower for exclusive vapors and smokers. So that is for the specific biomarkers we're looking at. There are a few of the biomarkers that are similar for smoking and for exclusive vaping. So those ones may be of particular concern, and we do need to do more biomarker studies. Okay, so that's the end of my presentation. I see I'm under my 15 minutes, but that's the main findings. Okay, thank you for listening to me.
Hi everyone. I'm disappointed not to be able to join the meeting today, but grateful for the opportunity to advocate treatment of tobacco dependency in pregnancy as a priority for a more equitable Scotland. My name is Sonya Scott, and I'm a consultant in Public Health and Public Health Scotland, where I lead work to improve outcomes for people in pregnancy. Over the next 10 minutes, I will give a brief reminder of the harm tobacco causes to pregnant people and their babies, and emphasise the nature of tobacco dependency as a medical condition, before describing the current scale of the problem in Scotland and what we know about what works to effectively treat nicotine addiction in pregnancy. Despite all the progress we've made in Scotland to reduce tobacco-related harm, tobacco addiction in pregnancy remains the single biggest modifiable risk for adverse outcomes for pregnant people and newborn babies, increasing the risk of pregnancy loss, prematurity, and baby death. As can be seen here, these increased risks are substantial. For example, due to the harm tobacco does to developing babies, those babies exposed are over 36% more likely to die before or during birth. And elimination of tobacco dependency in pregnancy would prevent almost 10% of preterm births and neonatal deaths, and over a fifth of small for dates babies and later child deaths. And it is not just the severity of harm caused by tobacco in pregnancy which makes effective prevention and treatment a population health priority. It is also the continued frequency of the problem which remains substantial, with thousands of women and babies affected each year across Scotland. It is important to remind ourselves that tobacco dependency is an addiction. Nicotine is the addictive component in tobacco, and it's highly addictive, thought to be second only to heroin and cocaine. Tobacco dependency can be a chronic, relapsing, remitting condition, often requiring repeated treatment for sustained abstinence. And knowing this can help us, both those of us living with the addiction and those treating it, not to give up. At any given time, 2 in 3 people want to be abstinent. It is also important to remember we're not all at equal risk of becoming addicted. Those of us living in more deprived areas are exposed to greater availability of tobacco and tobacco-related products, and in the past to greater levels of marketing. Most people become addicted in childhood, and we're more likely to become addicted if our caregiver or those around us are already living with addiction, so it becomes a vicious circle. As a result, baby and child inequalities in tobacco exposure are some of the largest inequalities we observe. The lowest social class babies are over 100 times more likely to be continually exposed to tobacco pre-birth to age 3 compared to babies in the highest social class. In one study, this was a magnitude of order greater than the next biggest inequality, which was for breastfeeding. This means tobacco dependency in pregnancy is a key indicator of likely wider social need and underlines why effective treatment of tobacco dependency in pregnancy is a social justice issue. So, what can we do about tobacco dependency in pregnancy? Prevention is obviously better than cure, and you might expect me to say that as a public health doctor. My colleague Garth Reid, Public Health Scotland's consultant for tobacco control, is supporting work at a legislative and regulatory level to prevent people becoming addicted in the first place. But whilst addiction risk remains, effective treatment services are essential. So what do we know about the current effectiveness of our treatment of tobacco dependency in pregnancy in Scotland, and how can we improve on it? This graph shows the variation across health board areas in the proportion of pregnant people receiving treatment who report maintaining abstinence for 12 weeks, with the purple bar giving the Scottish average. The first point to note is that high quality treatment does work, with almost 70% of people reporting prolonged abstinence in the highest performing board area. The second point to note, however, is that not all boards are currently achieving this level of success, with substantial variation across areas. Some of this will undoubtedly relate to variation in the implementation of evidence-based recommendations for effective treatment. So, what do we know about what does work to effectively treat tobacco dependency in pregnancy? While the National Institute for Clinical Excellence guidance includes evidence-based recommendations for effective service provision, some of these relate to the maternity service part of the treatment pathway and some are for the specialist service provision. The first is to measure carbon monoxide to assess tobacco dependency. This should be undertaken for all women at antenatal booking and at the 36-week antenatal care appointment, and routinely by maternity services if the woman has a current or recent tobacco dependency. The second NICE recommendation is that those who have a current or recent tobacco dependency at antenatal booking should be automatically referred to specialist treatment services, with the pregnant person informed that the next step in the treatment pathway is discussion with a specialist. This opt-out process supports patient autonomy by allowing them to get all the information they need to make an informed decision about receiving treatment for their addiction. Research shows that the chance of treatment success is improved if anyone living with a pregnant person who has tobacco dependency receives treatment at the same time. So the third NICE recommendation is to ask the pregnant person if anyone else in their household is a tobacco smoker and offer to make a referral for them too. This has the additional benefit of proactive reach into families and communities likely experiencing high prevalence of tobacco addiction. The recommendations for the specialist service provision are, firstly, that the main treatment should be intensive ongoing support, with nicotine replacement therapy considered as an adjunct. Secondly, that financial incentives are offered. I think of financial incentives as financial stress therapy. Whilst the term financial incentive relates to the effectiveness of the intervention in increasing engagement with treatment services, the evidence shows that they also increase the chances of treatment success. And one possible explanation for the latter is that relieving financial stress supports maintenance of abstinence. The third recommendation for the specialist service is that carbon monoxide monitoring is used throughout treatment to provide feedback, and that abstinence is biochemically validated rather than just self-reported. And finally, specialist services are recommended to continue treatment into the postnatal period to prevent relapse. In summary, tobacco dependence, despite all the progress we've made in reducing it in the population, remains the single biggest modifiable risk factor for adverse outcomes in pregnancy. Nicotine addiction is a chronic, relapsing, remitting medical condition, but evidence-based treatment is available. We're not all at equal risk of developing the addiction, and tobacco dependency in pregnancy is an indicator of wider inequality. Therefore, prioritising the delivery of high-quality tobacco dependency treatment in Scotland is a matter of social justice and will literally save babies' lives.